Today, we're going to talk about the host factor. So when we are doing those salivary tests, when it says there's a low pathogenic load on the gum inflammation score, where do we go from there? So super excited. We're going to be talking about some of the salivary tests. And when we do have a salivary assessment with the periodontal risk and we're not seeing the typical red complex pathology in there, what can we look at in the test to understand what's causing disease pathways? So we are going to look at, the gut component. We're going to look at beneficial bacteria. We're also going to look at airway dysfunction. And I have some really cool case studies that will be walking you through some of the test results and picking apart the health history information and that test result so that we can give you some clues as to what to look for beyond just the gum inflammation score. So like I said, course description today is just to give you some hidden contributors to possibly looking at what could be a causative factor for your disease. So looking at airway dysfunction, immune imbalances, nutritional deficiencies, and those sorts of things that could also be driving factors beyond just the red complex pathology. So problem we're going to start with. So periodontal disease is an increasingly understood as an immune immodulated condition. So think of autoimmune component when we're looking at periodontal disease. It's not just the microbial presence that can drive tissue destruction, but actually autoimmune processes that can be also contributing factors to that collateral damage in the periodontium. So the solution is to test, don't guess, so that you understand the root cause of the pathology and can start implementing and leveling up your care on how to treat your patients. So of course, I believe that the oral microbiome is the gateway to understanding what's going on with our patients. There are over 800 fungi, bacteria, and viruses that can make up the entirety of the oral microbiome. And it doesn't just affect your mouth, but it impacts your overall systemic health as well. So salivary testing, implementing treatment, and then the salivary test can help you educate the patients on that oral systemic connection. So I think Bristol is extra special, not just because I work for them, but we use a different technology here with shotgun metagenomics. So shotgun metagenomics looks beyond just the limited version of a qPCR test where we're just looking at limited specific bacteria like the red complex or orange complex bacteria, or just a few of the pathology that would lead to decay issues. It helps us to uncover root causes of oral inflammation, and it can identify beneficial, harmful, and opportunistic bacteria. And this can support our treatment processes and help us personalize our care plans for our patients. So I'm going to go into a little bit of the details on qPCR versus shotgun metagenomics. So qPCR is a laboratory technique, and it's used to detect and measure specific DNA sequences in real time. It's highly sensitive and detects really low levels of pathology, and they give you a quantitative look into the bacterial load, but it's very targeted. So it's only looking at specific species that specific test is looking for. The shotgun metagenomics technology uses a DNA sequencing method that analyzes the entire genetic material within the sample. So it's a much more broad spectrum look at the oral microbiome, and it detects bacteria, fungi, viruses, and it can get all the way down to the strain level. So functional insights as well. So then we can give you an algorithm and functionality and give you a risk score based on what's there and who's playing in the sandbox. So you get a lot better clinical view, especially knowing where your beneficial bacteria are. I think that's a really important component in what drives disease processes. So the Bristol test is going to give you a beneficial reading, a gum inflammation reading, a tooth decay score, a halitosis score, a gut impact score, and a nitric oxide score. It also covers diversity. It's really important to understand diversity because diversity, depending on how many pathology are in there, we want a diverse amount of different bacteria. Sometimes we can have diversity issues that can also drive dysbiosis problems. It's also going to give you some really good insights on how the pathology is living in the mouth. And then we give you a really great ability to communicate with your patients through home care recommendations, and you can implement your office care plans directly in the platform and get those information to your patients. So it can help with communication with your patients as well. All right, so let's dive into the topic today. So disease processes, let's just go over the cycle and what the disease process has in the components. So biofilm dysbiosis is generally what we're looking for when we're doing salivary testing. We know that overgrowth of pathogenic bacteria can excite immune system responses, but we have to also have a susceptible host. So not everybody is susceptible to periodontal disease. I've seen plenty of tests where we have high pathology, but no disease, pink stippled firm tissues, but that patient just isn't susceptible to the autoimmune component of periodontal disease or bone loss. So we have to have a host susceptible. What causes susceptibility within a patient? So we could have a genetic disposition, immune system dysfunction, hormone fluctuations, lifestyle issues like smoking, drug use. We could also have a systemic condition like diabetes that can enhance the body's immune system response, making that host more vulnerable to the pathology in the mouth that leads to disease and inflammation. So we have to have an inflammatory response as well. So sometimes, even if we have a host susceptibility like diabetes, it'll also drive up those inflammatory issues, which involve the cytokines, interleukins, tumor necrosis factor alpha. So those inflammatory cytokines then lead to that tissue breakdown and disease progression. So I like to break that down because we can have dysbiosis and not a host that's susceptible. And we can have a susceptible host that's driving inflammation who's susceptible to periodontal disease. And that will make them have a less susceptibility, or they'll be more susceptible to disease pathways even with less bacteria present. When we're talking about the oral microbiome, it's really important to understand the differences between homeostasis and dysbiosis. So homeostasis, you're going to have low levels of pathogens that help to train your immune system, and that helps to keep the community stable. Believe it or not, you're always going to have pathogens. We can't kill 99% of germs where we are bacterial beings. Beneficial bacteria in homeostasis are really important to have high because they help to promote a healthy pH. They help with remineralization factors. They help to train our immune system. And good bacteria in the mouth help to actively suppress pathogens that cause disease pathways for our patients. Without having both beneficial and some of those pathogenic bacteria, we don't have a very stable and environment, and we're susceptible to drastic shifts. And in those shifts, we end up with dysbiosis. So a lack of beneficial bacteria can allow pathogenic overgrowth and invasion. And when we have an overgrowth of pathogenic bacteria, that leads to disease pathways like high inflammation with periodontal disease and gingivitis, and maybe even acid production that leads to decay issues. And of course, we always want to make sure that we're treating dysbiotic communities because we need to treat the root cause of what's happening. So it's really important to understand dysbiosis versus homeostasis. And I like to point out too, like our goal should be, if we do have a dysbiotic situation, we want to reach homeostasis. So testing and retesting is really important to know that we've actually returned to a balanced oral microbiome. And diversity is super important. So one of the call outs here is understanding that there are opportunistic infections that take place within the oral environment, and it can cause severe dysbiosis. And in those dysbiosis, this is kind of a really cool example. I've seen there's about 5 different bacteria I'm going to be doing a presentation for the IOMT on low diversity and how that matters. But this Enterobacter species is taking up 70% of the oral microbiome. I brought in this cool pie chart just to show you what that actually looks like in like the perspective of a garden. So this is a weed taking up 70% of the oral microbiome, and that's a significant dysbiosis. And this is not one of the red complex bacteria that we would be looking at, and it's not really in the inflammatory score in the bristle test. So why do I bring up Enterobacter species, and how does it impact periodontal disease? So go ahead in the chat. You can go ahead and answer. I'll give you a minute. Okay, so we have some C, it impacts gut health. Amazing. Okay. So yes, it will impact gut health, and Laura, good job. It is also a biofilm former. So it's going to be biofilm based, and it definitely impacts gut health. And when we have an impact of gut health, we swallow that bacteria and it ends up in translocation. So we can have translocation of bacteria from the oral environment that makes their way down into the gut. And in that process, it can cause gut barrier dysfunction and leaky gut issues, which drives up immune cell activation and leads to IBD or irritable bowel syndrome. And then in return, that irritable bowel syndrome will cause inflammation, extra cytokines, and then drive disease processes for our patients with perio. And then also, don't forget that, Enterobacter isn't in here when it comes to this, but, PG, Trinella forsythia, all are tied to that gut dysbiosis as well. But in this little demonstration here, you can see not only does it go into the gut, but we also have that translocation into the bloodstream, which has an impact on immune systems with autoimmunity, with cancer, with gastrointestinal diseases. It can impact our endocrine systems like our thyroid, which has impacts on the bone as well, and metabolism, heart disease, and neurological issues we know are tied to that component as well. So coming back to the Enterobacter grouping, I brought this kind of fun chart in. So Enterobacter is in a similar family as Klebsiella. It's actually the same Enterococci family. And for some of those who are using a microscope, Klebsiella pneumoniae is non-mobile, but Enterobacter arans is mobile. So it's one of those mobile bacteria that is still forming a biofilm. It is found in the oral cavity and the GI tract. And it is similarly opportunistic as Klebsiella pneumoniae, and both of them can impact your immune system responses, form biofilms, and they're linked to conditions like sepsis, liver abscesses, colitis, IBD, and dysregulation. Halitosis, this bacteria is really known for halitosis issues for a lot of my patients. But notice it triggers inflammatory responses. And when we're releasing cytokines, that can feed our periodontal disease with those interleukins and tumor necrosis factor alpha. And it leads to bone loss in that perspective. So that brings us to the host component. So periodontal disease is a chronic inflammatory issue. It can be derived from pathology, and it can also be derived by our host inflammatory issues as well for our patients. So here's another fun question. You can drop your comment into the chat, but diabetes increases the risk of periodontal disease by how much? Any guesses? We have a 32, a 24. Any other guesses? Awesome. 24%. So diabetes increases our risk for periodontal disease by 24%. So that's significant. So other factors too with diabetes and periodontal disease is individuals with periodontal disease have a 26% higher risk for developing diabetes. So it's a bi-directional situation. So in diabetes, hyperglycemia raises inflammatory mediators, interleukins, in the gingival crevicular fluid, and it worsens periodontal status. In periodontal disease, gram-negative bacteria elevate systemic inflammation with CRP and tumor necrosis factor alpha, which then contributes to insulin resistance issues and impairs our glucose control. So my point of bringing diabetes up, because we all pretty much know that there's a bi-directional nature when it comes to diabetes and periodontal disease, but a lot of diseases are bi-directional in nature. So periodontal disease is associated with multiple systemic conditions: diabetes, metabolic syndrome, obesity, fatty liver disease, cardiovascular disease, Alzheimer's, rheumatoid arthritis, cancer, and adverse pregnancy outcomes. But the key mechanisms once again, with this little diagram, we're looking at the host factor and what's going on with our host that makes them susceptible. So we can have the susceptibility with the perio that has started, right? But systemic inflammation that the patient may have through diet or lifestyle, and then other systemic diseases as well can drive up that susceptibility. We can have dysregulation of the immune system that can drive up that susceptibility for our patients. And then, of course, that bacterial component as well will drive our disease processes. So inflammation, immune dysregulation, and environmental factors all play a role. And of course, hormones and stress can play a role in that bidirectional aspect as well. So when we're talking about diabetes, we have to talk about sugar. And we all know that we talk about sugar with caries issues, but sugar drives inflammation as well. So I think diabetes is one of those situations where, if you think about it, my sister-in-law is type 1 diabetic. So she has to keep sugar right next to her bed, because if she drops low, she's eating Skittles in the middle of the night. Well, those Skittles are helping with her insulin to try to bring that back up, but it's also driving inflammation, which then leads to an increase, probably dysbiosis in the oral microbiome, but then also added inflammation in itself, because we know sugar will drive inflammatory responses, increasing those interleukins once again. So diet plays a huge role in that component. And if we look at nutrition, this study showed that nutrition is actually the most modifiable factor in prevention of disease, including periodontal disease and some of the chronic diseases like diabetes and cardiovascular disease and cancer. So diet plays an enormous role in the inflammatory response of our patients, both orally and systemically. So let's just dive a little bit into nutrition for a few minutes. So one of the things that I like to talk about with nutrition is we need to have our key fatty vitamins and some essential minerals that are involved in helping our patients with healing. So our vitamins and minerals: D carries calcium, K2 lays it into the structures. It's going to help with that metabolism of the bone. But vitamin A, deficiency symptoms could be dry mouth and gingival inflammation, impaired healing components. We know that vitamin C helps with collagen synthesis, with tissue repair. So we need to make sure our patients are vitamin C sufficient. So taking a vitamin C can help our patients. That's going to help with our bleeding points and our healing component. Calcium doesn't move without vitamin D and K2 together. So, and then the B vitamins are very important for energy metabolism, DNA synthesis, and can reduce the glossitis and mucositis. So mucositis, more inflammation, right? So these are important aspects to understand, because if we have a gut dysbiosis problem and leaky gut issues, we end up with vitamin deficiencies in the process. So the other topic we're going to kind of dive a little bit into is airway. So how do airway disorders impact the oral microbiome? Anyone want to drop a little line in on some things that it could impact for us on the airway component? Dehydrating, dry mouth. Yes, absolutely. So this is like a famous actor. We all kind of know who this is, and he's the typical mouth breather patient. In the salivary test, I have found nitric oxide. Good job, Lauren. Nitric oxide in the salivary test is a really nice indicator on possibly if we have a mouth breathing issue and an airway problem. So really pay attention in the bristle test on that nitric oxide level. So in the bristle test, we look at the ability of the oral microbiome to break down dietary nitrate into nitric oxide. And that's a really important part of vasodilation. It's part of immune system function, and it's part of insulin resistance. So super important components. We don't actually look for nitric oxide in the test. We're looking for the bacteria capable of reducing dietary nitrate into nitric oxide. And there's, different salivary factors that play a role in that. So let's just talk about the nitric oxide pathway for a moment. So you take dietary nitrate, and those are in beets, arugula, spinach, celery, and you chew that, and the bacteria in there start converting that to nitrite. And in that nitrate gets then transitioned into the gut, and that nitrite gets transitioned to nitric oxide. And then about 25% of that comes back in the saliva. And that's really important, like I said, for glucose regulation, cognitive function is involved, wound healing is involved, and it also is going to help with that cardiovascular health. It helps with tissue integrity. So it's a really important component of the oral microbiome. And actually, I read a really cool article recently that supplementing with a nitric oxide supplement and having higher levels of Rothia aurea will decrease our perio-pathogens in the mouth. So when we increase those bacteria, and we're feeding them with good food and diet and doing supplementation, we can help our patients as well. Of course, it's really important to understand that there is an impact with antiseptic rinses. So this 7-day study showed use of antimicrobial rinses, antiseptic rinse, for 7 days decreased the nitric oxide levels in the patient significantly. And that ended up leading to blood pressure and vascular health problems. So we don't want to overuse antimicrobial rinses. And if we don't have those good bacteria in the mouth, it could lead to high blood pressure problems with our patients. So that's a really important component to understand as well. And breathing disorders can impact that component for our patients as well. So microbial imbalances and systemic stress can profoundly impact the oral health by disrupting the normal immune system responses and leading to inflammation. So dry mouth conditions drive an exaggerated immune system response involving our T helper cells, and that increases our interleukins in the oral tissues and it contributes to that inflammatory response. So it's really important to make sure that we don't have mouth breathers and that we're dealing with our patients who are having a mouth breathing issue. So one of the first things that you need to do is consider a sleep study if you identify that you have a mouth breathing component. So oftentimes if I see a low nitric oxide score, I'm having the airway conversation, especially if we're not overusing antimicrobials. The first thing I usually ask is, are you using Listerine or chlorhexidine or some of the over-the-counter rinses. If they're not, then generally I'm looking at other scores to see if I can correlate whether there's a mouth breathing component, and then I consider a sleep study. So sleep studies are super helpful. It's a polysonogram, and it's a diagnostic monitoring to look at breathing patterns, oxygen levels, and brain activity and muscle movement to diagnose whether we have sleep disorders like obstructive sleep apnea or insomnia and restless leg syndrome. So important to identify by those. If we have inflammation in the mouth, and even without periodontal pathogens, this can profoundly impact. I like to remind people that if we don't get into deep sleep, we don't heal. So we need to get into deep sleep because that is where our bodies are regenerating, detoxifying. So if we're constantly in fight or flight mode because we're waking or we stop breathing at night, then we're not in that healing component. So sleep is vitally important. And if we have a CPAP machine, it does make it a little bit more challenging sometimes to get that nitric oxide score up because that can sometimes be drying. So sometimes I talk about CPAP treatments along with oral appliances. And of course, I think it's important if we have a sleep issue that we also deal with the function of the tongue and check our airway components and make sure that we're looking at our Mellon-Patty score. So this is a little diagram of Mellon-Patty score. If you guys aren't checking Mellon-Patty, I think it's really important aspect. If I'm doing some of the result reviews, there's sometimes I'm like, okay, what's the Mellon-Patty score? Do we have any, issues? What's the face look like? I can look at someone in our coaching calls now and be like, I'm pretty sure we have an airway issue. I'm an airway patient. I've got class 2 bite. I have a tongue tie in that component. But it's found that mouth breathers with chronic periodontitis exhibited less improvement of gingival inflammation and bleeding after scaling and root planing in comparison to nose breathers. So we want to try to encourage nasal breathing for our patients because that's going to increase and improve our patient outcomes. So myofunctional therapy, we need to make sure we're getting in. And then the consequences of xerostomia, I think that's important. So if we're mouth breathing, you're going to make the mouth more dry inherently. That's going to drive pH level down, making it more capable for pathology to grow that causes disease like periodontal disease or causing decay issues. But increased fungal infections are a consequence of xerostomia halitosis. Burning mouth syndrome is also another correlation with xerostomia issues. I usually say when we're using the bristle test, it's a really great time to do a salivary assessment. Take the time when you're having your patient do that spit test right chairside, make notes. It was frothy. It took a long time. Do a salivary assessment there because if we don't address and implement some xerostomia, substances like Periovance or possibly like Oral 7 is another great product that have oral enzymes in them. Salvia is another one that's really great that has salivary enzymes in it to mimic saliva. Doing xylitol sprays can help us with xerostomia issues, but if we don't push the xerostomia issue, then it's really hard to gain a balance in a dysbiotic situation. So I get super passionate about interpreting the test, especially with perio. So I'm going to kind of spend a little bit of extra time on this slide. Generally when we're doing salivary testing, we're going to think about having high inflammation scores with our inflammation. And honestly, 90% of our cases are going to be in that category. Of course, these are going to be your 43, 46 or your scaling and root planing patients. And I really encourage going above and beyond and leveling up your care and adding in adjuncts like laser, like ozone, perioprotect trays, possibly systemic antibiotics. I have never used antibiotics. I know some offices do. Localized antibiotics like Arestin. And I'm really loving the outcomes that I'm seeing in science on the desiccation therapy. So really, when we're talking about that Enterobacter, it's a biofilm. So we need to deal with the biofilm, even if it's not a red complex bacteria. So Some pathology is SRP resistant. So if we have PG and AA and some of those other red complex bacteria, we know just the cavitron alone isn't going to help us in that component. So adding in something that penetrates the tissues like laser or desiccation therapy can help us reduce biofilm, because that's what we're dealing with. And of course, you should test these patients more frequently until you get them stable. And don't think of it as a failure if you didn't get good resolve in the first try. That just means we're not done treating, which gives you a better understanding of the patient's susceptibility and how easy they're going to push for the oral microbiome. If you're having a hard time pushing that patient, then you also need to look at the gut impact score and that nitric oxide score, because if we have a breathing issue or a gut issue, they're going to be harder to shift as well, especially if we have acid reflux and some of those components. If you're testing more often, there are patients that won't have any inflammation. They're pink, stippled, firm, and beautiful, but they'll have a high gum inflammation score. These are our patients who aren't susceptible to periodontal disease. Once again, that's an autoimmune component, right, that drives that disease process. It doesn't mean that they don't have high CRP, and it could be leading to systemic inflammation with all of those correlated diseases that we have over 3,500 studies for. So I do challenge you, those patients, your D1110 patients, your prophy patients, would probably be benefited by added adjuncts like laser bacterial reduction, guided biofilm therapy, perioprotect trays, ozone treatment, and in all honesty, you could do desiccation therapy on that patient as well. So consider reducing that pathology level even in your non-inflammatory patients. This is the category that we're talking about today. So the low inflammation risk with inflammation present. So it indicates that there's a lower threshold for that patient for disease. So they're high responders. With that high responder, I really encourage you to look at the gut impact score, look at the nitric oxide and the beneficial score, and see where those levels are to try to figure out where your disease processes could be coming from. Really read into your health history information, look for airway issues, do your Mellon-Patty scores, look at salivary health, and ask about the gut in that component. You know, do you go to the bathroom a lot? Do you have to go to the bathroom immediately after eating? Do you poop? Some people, you know, are bound up, and that's a GI issue. So I know we're supposed to stay in the mouth, but those things impact nutrition and inflammation for our patients and could be drivers of disease. Things you can consider for those patients. Periostat is a great product. It's a low dose doxycycline. It's not an antimicrobial in any facet, so we don't have to worry about causing any resistance factors, but it's dealing with the host component and the inflammatory response with our patients. There are some other really cool products on the market too. OSA is a product that helps to deal with the neutrophils and the white blood cells that are driving the inflammatory response. So sometimes we can have those neutrophils in there. It's not really dealing with dysbiosis, it's dealing with the inflammatory issue in that perspective. These patients could be really nice to get an MMP8 level on. That's another indicator of tissue breakdown for your patients. So now that I've kind of wrapped up like some of the things that we could look for in the test, I want to dive into some case studies for you. So this case study was shared by one of our offices. So thank you, Water Tower, for sharing this case study with me and all of your patient information. So here is our clinical data for this patient. So we have a full mouth series, and we can see a couple things on there. Obviously, there was some trauma in the anterior teeth. We are congenitally missing, or we're missing lower laterals. What else do you guys see in this that you might be red flagged with as far as the history? We have generalized 4 to 5 millimeter pockets, which have been pretty much the same throughout all of this perio charting. We have number 9 that looks stable. perio around implant, possibly, depending. The cuff is kind of lower there, but the charting is around a 4. SRP was done in 2011 and 14, and this person has stayed on perio maintenance, 4-month recalls, and they've used laser intermittently. But lately he's been getting a lot more inflammation, so they decided to do a test. So kind of diving in again with the perio charting, that kind of leads to salivary testing. In here, we still have some 5s and 4s, but posterior 5s that have been pretty consistent and not really resolved in this area. So what's really causing, if we've done our SRP and we've done all of our treatments and he's stayed on a recall, let's look at his intraoral camera pictures, because this can kind of tell us a little bit different story. So couple call outs here. He definitely gets buildup. You can see that tartar buildup on the lower teeth. We do have a cross bite on the between 19 and 14. So there's a little bit of a concern there. Vaulted palate. Not super clear on whether there's a tongue tie there, but you can see in that lower anterior one, there's a lip tie on the lower anterior. But I put the lower molar in because he's definitely susceptible to some decalcification. But where they tried to take the picture of the molar, you can see his tongue just doesn't get out of the way in that component, and you can definitely see the inflammation. So there's a couple things in here. Probably, yeah, previous decay issues, possibly some stomach acid is some feedback there as well. So the first thing I think of with his bite and his palate and some of the tie issues and how his tongue looks is he's probably airway as well, especially missing teeth in that component. Health history wise, we really didn't have a whole lot on his health history. He's taking Vyvanse or ADHD medication and a multivitamin. I think that that's important. One of the big side effects for some of these medications are dry mouth issues, so we have to take that into consideration as well. And can anyone else tell me too where attention deficit might also come in with some of the test results, or some to sleeping disorder? Yes, that's the other component. Good job. So ADHD is tied to airway health and a sleep disorder as well. So that's something to kind of evaluate when you see your patients on these types of medications. So let's just analyze the sample for a few minutes. So we have really low beneficial bacteria. So we already know that we probably have a little bit of an imbalance in that component. And he has a lot of inflammation, but we don't have all of the pathology typically we would look at in, for the red complex or orange complex bacteria that would drive the gum inflammation score. Any other things that you would kind of call out here? We have a high gut impact score and a low nitric oxide score. So that nitric oxide score should be high and in green, and that gut impact score should be low and in green. So I immediately think airway possibly, especially with the pictures that I saw, and possibly sleep because of that medical history. And then also there's a gut impact. So let's dive in a little bit and we'll talk about the beneficial. So like I said, those were low. And I have noticed a little bit in some of the beneficial bacteria, a little bit of a slide. Sometimes you can start to see that dysbiosis start even in the beneficial bacteria. So if you look here, he's really high on the anaerobic bacteria that are beneficial. So I'm seeing a little bit of a shift when the mouth starts to take a little bit of a tank. We can start to see the beneficial bacteria even be in that anaerobic. Most of the beneficial bacteria are aerobic or facultative. Some are anaerobic. So you can start to see a little bit of a pathway issue when you see that anaerobic environment. Generally, anaerobic bacteria high in the mouth leads to decay, disease issues. So homeostasis, super important. We want to get these beneficial bacteria up. So strategies for doing that, we can focus on monitoring our pH. So oftentimes in my care plans, I'll talk about pH strip use and checking oral pH. Using xylitol products like Spry, Theramins, Xylamelts. Sometimes I like sprays that are super helpful at helping with pH. And then, of course, hydration is really important. I talk to people all the time because sometimes individuals are drinking lots of water, but maybe they're drinking reverse osmosis water. And there's no minerals in there for hydration. So you can drink all you want, but water crosses the cell-brain barrier through an ionic process. So anyone who is on any type of reverse osmosis or filtered water, I usually encourage adding in a pinch of Himalayan salt or Celtic salt, or making sure that you're adding electrolytes in so that you are actually hydrating in that perspective. And then understand some bottled waters or some water can be on the acidic side as well. So really pay attention to some of that perspective. And we'll just talk a little bit about pH as well. So pH shifts in periodontal disease, and we can shift it with treatment of periodontal disease. So in general, someone with periodontal disease, the more severe they are, you can see in this little chart here that in stage 3 and 4 periodontal disease, you're going to have a lower pH, salivary resting pH. So it'll be below like I would say 6.25. And that those periodontal pathogens will bring that down in that perspective. So I love using pH to boost them out as well. So my theory is, okay, we're going to get the pH where they don't want to hang out. They like to be at that 6.25 level. So if you're not pH testing chairside, sometimes that can be super helpful in understanding our patients and their buffering capacity and sometimes their bacterial load. So in this, on the right side here, you can see after treatment at 3 months, a lot of that pH component has subsided after treatment. So don't just think about like pH and how it impacts the beneficial, but pH in disease will also shift as well. So the more we can push pH, the happier the mouth is going to be. Other ways that we can do some tricks with helping with our beneficial bacteria is, of course, oral probiotics, and diet makes a huge difference. So we can add in oral probiotics and they can help us balance as well. They act as bacteriocins and they use basically hydrogen peroxide processes to help correct and shift the biome. I talked about these as kind of being companion plants for the garden. So we put Lactobacillus rudii in there and they help to kill off and inhibit the growth of some pathogenic bacteria, and that reduces inflammation in the mouth. Lactobacillus plantarum is another one that's really valuable, specifically like Treponema denticola is susceptible to Lactobacillus plantarum. I like oftentimes using a variety. Sometimes I'll use specific strands. Like if I have a mouth that's high need for Lactobacillus rudii, I might start with one product. And then I usually carry over, especially if I have a low beneficial score, into a more broad spectrum like the Bristle brand that has 6 beneficial strands of bacteria that have science backed behind it. That one also has a bifidobacterium, which helps with gut health in that component as well. So diving a little bit further into the test results. So his halitosis score didn't really scream at us very much, but some things that you want to look at in the halitosis score is the type of halitosis that shows up. So sometimes if you have a high pathology in the gum inflammation score, it will be a gum lining in nature. But the tongue coater nature I'm finding will oftentimes correlate with a lower nitric oxide score. So if we have a dry mouth and a mouth breather, it will inhibit the growth because the bacteria that are tongue coating in nature are generally anaerobic or facultative, and they coat the tongue and inhibit the nitrate reducing bacteria that also live on the tongue that sometimes are aerobic, so they can't tolerate that. So that's where some of those beneficial nitric oxide bacteria will be. You'll just have the anaerobes present and not a lot. So if we add oxygen in, make sure we're tongue scraping, we can help improve that as well. So that nitric oxide is really important. Like I said before, you can kind of look at how they're growing. So this was low, and precisely what I was talking about in his score. He's more on that anaerobic side. So we really want to get some oxygen in there and make sure that we're disrupting biofilms, because the ones that are surviving for the beneficial ones are those anaerobic bacteria. So how do we do that? With strategies for the tongue coating bacteria, we can do tongue scraping. You can use a soft bristle brush. I usually like tongue scraping. I kind of joke, our tongue is a shag rug. We don't use a vacuum. We don't use a brush or a broom to clean up the rug. We use a vacuum cleaner. So tongue scraping is more like a vacuum cleaner versus a bristle brush. But sometimes if the plaque is thick on there, use a soft bristle brush. Make sure you're not being overly zealous with it, and have them then do the tongue scraping. It might just help break up the biofilm so that you can pull it off with that tongue scraping. Ozone water is super great for a rinse. Hydrogen peroxide, it's H2O2, can help reduce. And then things with herbal rinses or green tea, those polyphenols can help reduce some of that bacterial adhesion on the tongue as well. Be aware though, with hydrogen peroxide rinses, sometimes that will induce black hairy tongue. So I have had that happen with some of my patients. Even chlorine dioxide I've seen in that perspective. So I do love ozone in that perspective, but just regular tongue hygiene and really supporting the pH and making sure we don't have dry mouth issues. So let's dive into his gut impact score a little bit. So he has high Campylobacter, and there is some Fusobacterium in there. Campylobacter is susceptible to Lactobacillus plantarum. The one that is in there is facultative. Those facultative ones gets a little bit more challenging because it can live in or without oxygen in that component. But when we have a high gut impact score, that can lead to disease pathways. We're not checking whether we have actual dysbiosis, but if we are swallowing all of these bacteria, we know that there's a high correlation with these bacteria that can increase problems with the gut barrier function, and that can lead to IBS and Crohn's issues and inflammatory issues in the mouth. So pay attention to your gut impact scores in that perspective. And his diversity was within range. I do want to just call out though, within range, it's just looking at like a core number of bacteria. But let's just point out he had high pathology in the gut inflammation score, which was high, and he has low beneficial and he has low nitric oxide bacteria. So he is still in dysbiosis even though he's in range. So I do look at the diversity score in some components, because sometimes the diversity score will give me some percentiles or main bacteria that are also listed in the raw results at higher levels, and I start to dive into some of those components. So if I'm not seeing a lot of pathology in the gum inflammation score, I love to dive into the raw results section. So in the raw results section, you can get a list of all of the bacteria that we found in the oral microbiome, and will give you a relative abundance, a percentile, and some of the associations with that. Now, I'm a super nerd. I love looking up all these bacteria and providing education on them. So not everybody is going to have the time and expertise to do that, but that's why I love doing what I do, because I get to teach you. This is just a real brief overview. I just pulled the first few that were in his score. But one of the things that I'd like to point out, that Campylobacter that's pushing his gut impact score is at 2% relative abundance. That means it's at 2% of his entire oral microbiome. And in the percentile range, that means he's in the 99th percentile of all the tests we have. So it's pretty high in comparison to everybody else. So that's something to kind of take note of. And there is another Campylobacter species right under that in another high category. The big call out here though is Prevotella. This I'm not going to pretend to know how to say the last name, even with all of the science that I read. But this Prevotella M species is a monochromic bacteria that can cause black line staining. It's also associated with inflammation. And if you look in general, here's another Porphyromonas group that's at 7% as well. So there are some inflammatory bacteria. With that Prevotella M, note that it's at relative abundance of 20. That's a big call out. So let's just look into Prevotella for just a moment. This specific species, I brought in this really cool pie chart to show you what that looks like in relative abundance. So think of this as like the garden. So at 20%, that Prevotella species is taking up his space in the garden. Then we have leading Porphyromonas group at 7%. So PG is inflammatory. So you can assume that this Porphyromonas species is probably also inflammatory. And then we have a couple of other Prevotella species as well in here that could also be driving some inflammation. So Prevotella, when I looked at, it is a periodontal pathogen. It does cause tissue breakdown, and it's also correlated to ulcerative colitis. And it can impact our gut health by shifting and triggering inflammation. So that one is important. Really pay attention to this one because this is one I see naughty a lot in the backside. So if you're looking for insights for inflammation for your patient, look for this Prevotella species. I see it quite a bit. So of course, this one is a biofilm as well. So we want to level up our care when it comes to treatment. So things that we could consider, it's been since 2014 since he's had SRP. I would treat him again, even with the low gum inflammation score, because we know we have biofilm-based bacteria that could be driving some of his factor by route of translocation, possibly. Treatment with lasers would be best, or desiccation therapy. Ozone tray treatments could be considered. You could consider gingival irrigation. Because he might have a gut component and an airway issue, maybe periostat would be a better or a thoughtful option too to address the systemic aspects of things. And of course, there's some other things that we could absolutely use in the office, OHI instruction. We could consider nutritional counseling, especially if there's any gut component in that aspect. So this is kind of what I would probably put him on as far as home care. I love biocidin, and the combination of biocidin, which is also a biofilm disruptor, with ozone is really fantastic. And then I love Supermouth. Supermouth is a product that has inulin, vitamin D, and K2, and it is pH'd at 8.5, so can be super helpful with supporting saliva health and remineralization components for our patients for that. So treatment for home care, I really focus on biofilm disruption and using a biofilm buster with the biocidin, and then bringing in oxygen with an ozone water flosser and possibly some ozone gel to add an extra oxygen for those anaerobic bacteria and supporting our beneficial bacteria that do tolerate and like oxygen. So I'm seeing a really nice shift with ozone use and helping to build those beneficials. And of course, xylitol is going to help, and pH balancing is going to help too. So thinking beyond brushing, some prebiotics or probiotics, the Bristle brand would be what I would recommend due to the variety grouping that his score indicated. And then I would add in things like a nitrate supplement, an all-day dry mouth spray, a Periovance oral gel. I like combining gels and sprays. So gels are great for nighttime use. If we have a mouth breather at nighttime, we can put a gel in. No one's gonna ever really walk around with a gel during the day and putting it in the mouth. So I love using sprays where we can just do a couple sprays, work it into the tissues. It's pH balancing. And some of the components of the sprays have the enzymes in them as well to act similar like a saliva. I love monitoring pH. like we talked about before, critical pH, 6.25 for those periopathology. We know that that's going to also be more favorable for decay issues. So keeping us above that 7, which was that threshold in that study we showed, is bringing our patient into a healthy pH category. Mouth taping, if we don't have a sleep study, I love having my patients mouth tape. Really interesting is I've been monitoring my sleep, and mouth taping has improved my quality of sleep by increasing deep sleep and REM sleep just by mouth taping. So we can improve our patients' healing processes by assisting their sleep pathways. And that will also improve our nitric oxide, because when we're nasal breathing, that's another pathway for that nitric oxide reduction process. So we need to assist through referral options. So we found out that there's a possible need for a sleep study. I came to that conclusion based on some of the narrow palate, the low nitric oxide score. He's got malocclusion. He's missing a tooth, which has brought his airway in. The lower laterals have brought the airway in, making less room for the tongue. And he's in crossbite. So in one quadrant, he's in crossbite, which is already telling you there's an airway component with that aspect. Myofunctional therapy could be considered to help with that component as well. I think those two go hand in hand really nicely. And because of the pathology within the gut, it may not be a bad idea to work with a functional nutritionist or a functional doctor to work on gut component that might be driving the disease, since the SRP and the 4-month maintenances has not resolved his inflammation. Any questions there in the chat before I move to our next case study? No, awesome. Okay, so this one was one of my coaching calls, and he kind of fit the bill a little bit with this as well. I don't have any of his clinical information. I just have a lot of his information that he shared with me through some of my coaching and questions. So with him, oral health history, he had orthodontic treatment and his wisdom teeth removed. They did not do any serial extractions of bicuspids at all. He's had gum inflammation since he was in his 20s. He went through his first SRP in his 20s and then later had LANAP surgery at 28. So long time standing bleeding issues with all of his cleanings. He is remained on a 3-month perio maintenance schedule. COVID hit, like everybody knows, and he had a hiatus for 4 years after COVID, which a lot of our patients have had that. He has recently completed two quads of SRP, and he does have active decay present since returning. He is taking a multivitamin. Health history-wise, he reports mouth breathing at night. He is using myotape and is working on nasal support in that perspective. He does have a family history of diabetes. His dad was type 1 diabetes, or a type 1 diabetic. Chronic bleeding since youth. So what do we think about with chronic bleeding since youth? I think about the airway immediately in that perspective, and possibly some gut stuff. In the past, he did engage in some clean eating, like using Shakeology, and was doing workouts, and that improved his gum tissue inflammation. And he does have a CPAP machine, so he does have an issue with the airway. He doesn't always use it. So he reported to me sometimes he has several choking episodes at night. And I was like, you have to use your CPAP, or we need to go to your physician right away, and we need to talk about mandibular advancement devices, something that gets your airway open, myofunctional therapy, because those choking episodes are you not breathing. You could have a cardiac event and die. So when I had a serious conversation about the choking feeling, that's him not breathing at night. Gum inflammation issues, or he has gut inflammation issues, and he's going for a colonoscopy later this month to have that evaluated. So anemia, vitamin K deficiency, yeah, possibly, definitely some issues there which could be some of that gut component. So let's dive in and analyze his test results. So we have good beneficials. That's awesome. He's got a good base of beneficials. He actually said when he went to his perio, when he did go back, he didn't have as much perio loss like he was fearful of. So it could be because we do have a good base of beneficial bacteria. He does have an average inflammation, gum inflammation score, but if you look on the upper scoring of just like a general overview of some of the red complex, really not a lot of the pathology you would anticipate. The tooth decay score, he did disclose he does have active decay issues, so that's pulling there. I'll kind of walk you through that test in just a minute. Halitosis score, once again, is tongue coater in nature, and we have that gut impact and lower nitric oxide level. So those are some red flags there that we might want to look at in his test. So let's just call out and look here at the gut impact score. So we have several Campylobacter species and Fusobacterium, and then Klebsiella is also playing a role. Klebsiella is an opportunistic bacteria. It's picked up from surfaces. Klebsiella is in the Enterococci family, and it is susceptible to xylitol as well, and sometimes thiamol I use against it, and cinnamon. So have been pretty effective against those species. But they get really opportunistic in nature because they're facultative. They're some of the ones that will drive that diversity score really crazy. So, and this Klebsiella can be highly tied also to inflammatory outcomes. I took a course with Terry Walls, and she's doing the salivary test on the functional medicine side prior to doing a gut test because Klebsiella is highly tied to her MS patients with causing immune system dysregulation. So that's one to kind of watch for. So once again, oral health and autoimmunity. So oral pathogens like PG, F. nucleatum, Campylobacter, and Klebsiella can travel to distant organs through the bloodstream or through the digestive tract, especially when we have an oral barrier that's weakened. So we know he has inflammation already, so they make their way down. So there's a couple different pathways that can cause. Their translocation contributes to systemic inflammation and can compromise integrity of the intestinal barrier. So 4 ways that can be problematic is molecular mimicry, amplification of the autoimmune system through cytokine production, and that leads to autoantigen overproduction in that process. So these bacteria, when they're translocated, can excite, autoimmunity. And when we have all of these other inflammatory issues going on, that can then translate into inflammation in the mouth because they're all the same types of cytokines that we're dealing with. And once again, when we have a gut dysbiosis issue, vitamin D, vitamin B, K, A, and biotin are really important to understand. When we have dysbiosis and leaky gut issues, that can lead to a vitamin deficiency. So if our gut is leaky, it's going to increase our inflammatory cytokines, right? And that will feed the inflammation process. And then it leads to vitamin deficiencies because we can't uptake the nutrients from our food. And it can have health impacts by increasing inflammation, weakening our immunity, but it also has implications like bleeding, dry mouth, oral infection, glossitis, oral ulcers, and continuing with some of that inflammation that we're actually seeing in the mouth in that component. So what are some of the health factors that he shared that could be connected to his gut impact score? So does anyone remember much about his health history? So he had a couple big call outs on his health history information. And that included the fact that one, his family history has diabetes, which oftentimes can be type 1 isn't, but type 2 is definitely tied to dysbiosis issues. But chronic bleeding since he was a kid, there could be some gut issues related to that, leaky gut, leaky gums. And the fact that he shared that when he did do clean eating and he cleaned up his diet and worked out, he had better gum tissue health. So that tells you right there that his diet may be also a role. And I think this one was one I asked, like, how is your diet? Oh, it's good. I've had a pretty clean diet. And then I was like, okay, so what are you eating during the day? Like, what's your typical diet during the day? I was like, oh, okay. I don't eat a lot of sugar and I don't eat a lot of candy or have any soda. My morning routine is generally I have 3 muffins. I'll have pizza for lunch, and then maybe I'll have soup or like meat and a vegetable for dinner. I was like, okay, all right. I'm glad you're not drinking soda, but muffins are all carbs and so is pizza. So people don't correlate carbohydrates and flour products as a sugar that feeds inflammation either. So important to clean up the diet. If we don't clean up the diet, we're not going to clean up the inflammation. And he did indicate he's going for a colonoscopy. So when I asked him about his gut inflammation and if he had any GI issues, he's like, yeah, I'm actually having a lot of inflammation down there and I'm getting a colonoscopy soon. So colonoscopies are great. They're going to identify inflammation, but I always refer to someone who's going to deal with the gut dysbiosis and help with gut healing. Because just like in the mouth, we can look around, but you really don't know what the bacterial component is that's going on and where that's causing disease processes. So when I see that, usually I'm gonna be making a referral. So beneficial bacteria are good. That's probably why he didn't have a super progression with his inflammation, but he still has 4 and 5 millimeter pockets that he shared with me and needed scaling and root planing. So strategies that we could think about with that gum inflammation score is making sure that we're properly flossing. I don't know how many times I hand someone the floss. I'm like, show me how you're flossing. And they wrap it around their 2 pointy fingers. And I'm like, okay, let's change that and wrap it around our middle fingers so we can use our fingers and our thumb. Like getting down to the basics, like it's not like, hey, you should be flossing more. It's like, how are we flossing? Are we forming a C shape? I don't believe that flossing and water flossing are interchangeable. We have moving mobile bacteria and we have biofilm bacteria. I think your toothbrush, your floss, your tongue scraper assists with biofilms. A water flosser helps with Treponema denticola, P. gingivalis, Trinella forsythia. The swimming bacteria that are within a pocket need to be addressed with irrigation. And water flossing is the only way to do that. And it adds extra oxygen below the gum line to deal with those pathology. Proper brushing technique, super important, making sure that we're getting to all the angles, and using only short-term antimicrobial agents, and then really focusing on how we're going to balance out. Things we could consider in the office for treatment: laser bacterial reduction, laser-assisted periodontal therapy, desiccation therapy with Hybenex or Perio-DT does a really nice job at disrupting biofilm. And then ozone is amazing. So insufflation, water, or tray treatments can be really great options too for chairside treatments to disrupt biofilm. His tooth decay score, we'll dive into this a little bit. He is taking an oral probiotic. Notice in here, he has a high risk score, but really in this high risk score, it's really pushed from Lactobacillus plantarum. Lactobacillus plantarum is in our probiotic, right? We just talked about the benefits of Lactobacillus plantarum. He's taking the oral probiotic, but what happens is Lactobacillus plantarum will take hold in decay areas. So it doesn't cause cavities, but it actually will indicate that there might be a watch area or active decay lesion, and it'll stick in those spots and compete with strep mutans. So when you see Lactobacillus plantarum hanging out in this tooth decay score, it doesn't actively cause decay or an acid production. It's actually competing in an area where there might be decay happening. He is getting treatment for that. He's all scheduled. Way to support a healthy biome. Diet, super important. Alkaline, oral care, really honing in on the xylitol rinses and pH balancing. Hydrate, hydrate, hydrate. Salivary stimulating foods, eat crunchy things that help to stimulate your saliva. Chewing sugar-free gum can encourage. And then I always say, using supplementation, if we do have a dry mouth issue, is going to help us point that way. Reduce sugar, reduce processed carbs, and increase our nitrate rich foods like leafy greens, beets, arugula, spinach, celery, that can help boost those nitrate reducers. And of course, we need to address underlying issues like mouth breathing, gastrointestinal issues, and if they have acid reflux. Acid reflux can be gut related and it's also airway related. A lot of times, patients with airway issues will oftentimes have a side effect of that acid reflux. So if we have acid reflux or GERD, that's going to keep us more acidic. I usually, if someone has acid reflux issues, that's something to kind of talk about. Most of our patients who do have acid reflux issues are put on proton pump inhibitors. Proton pump inhibitors reduce the acid in the stomach, that then in turn reduces our ability to break down our food and leads to vitamin deficiencies in the end. They're not supposed to be on PPIs for longer than 6 months if you look at the bottle. So if I have patients who are dealing with acid reflux issues, I want to clear up the oral microbiome because we know some of those can impact that. I want to look at airway, and I'm going to send them to a functional nutritionist to deal with healing the gut rather than just popping a medication in, lowering the acid level and hoping that's going to solve the problem, because we'll have perio and caries down the road if we stay on that product. And we already talked about this component as well, so we'll just kind of skip that one. But leveling up care for him, I did recommend possible doing ozone treatments in that perspective. We could consider laser bacterial reduction or desiccation therapy. He is seeing a holistic dental practice. I did talk to him about seeing his functional or holistic practice who does deal with airway, and I said you have to have the sleep apnea conversation with them. If they are treating airway issues, please make sure that they're treating you for your airway, especially with the choking aspects that you're indicating. This was a home care. I do love biocidin. I'm getting wonderful results with biocidin and ozone. So it is probably my first go-to for treatment if I don't get good results with the combination of biocidin and ozone. In that perspective, then I'll try some other products. Of course, his were more biofilm based in that perspective, and that's why I chose that. There are certain bacteria that I might choose something else. For instance, like Klebsiella, Serratia are sensitive to xylitol, so I'll pick a really high xylitol rinse in treatment for that as well. So, and then beyond brushing, of course, we're going to support that dry mouth component again. And we're going to bring in some things that are supplementing that nitric oxide. And I'm going to encourage nasal breathing, encourage pH again. So a similar layout for that. And we're going to assist with that referral component as well, especially because he said he was choking. So I want to make sure we're taking care of the airway so we don't have a heart attack. I think myofunctional therapy is really important in helping to encourage nasal breathing. And myofunctional therapy in the studies have shown if we incorporate myofunctional therapy with our obstructive sleep apnea patients, we can have a better outcome with the use of our devices. So we can really have less air shoved down their throat with actually helping to fix the tongue posture in that component. So super important to incorporate some of that. And of course, the functional nutrition side to deal with some of his gut issues. I did give him a referral for a functional nutritionist because he did have so many gut issues going on and he had that colonoscopy happening. So I want to make sure that we're dealing with any bacterial overgrowth in the stomach and sealing and healing the gut so that we can have a good transport of his vitamins and minerals in that component. Yay, thank you all. So we can go ahead and open up to questions. Colloidal silver and nano silver work for, I like colloidal silver. I've used colloidal silver personally and I've seen good results. I think it is more broad spectrum colloidal silver. So I have seen it impact the beneficials. So it should be treated as a treatment. Think of it as an antibiotic, much like some of the others. So don't regularly use colloidal silver. The nano silver in Elementa, I'm not sure how that impacts the beneficial ones. I don't have enough test and retest to, I do love Elementa with the nano silver. It is a different form of silver. I just don't know how it impacts the beneficial bacteria long term. Anybody else have any other questions? You can find me at heatherkennyrdh.com. I do coaching on the side. I do coaching for Bristol as well. I do dive a little bit further when I'm doing personal coaching because I try to correlate and connect with the providers, get x-rays, and really do a deep dive for those patients. And then follow me. Amanda Hale and I just started Functional Roots podcast, where we are exploring and talking about the root cause of oral and systemic diseases. And we just launched that, and super excited to be talking about a lot of this on a podcast and sharing in that perspective. So, any other questions? Awesome.
Okay, awesome. Well, we'll be sending out a recording as well. So if any questions come up at that time, you can respond to those. We'll make sure those all get routed to Heather. But I just want to make sure I give a huge thank you, Heather. Fantastic presentation. I enjoyed it a lot. I'm sure everyone on it did as well. So fun, just digging in on all the mysteries and how you can really leverage all that information to expand your care. So really appreciate it. For everyone else, we'll be sending out the recording probably tomorrow once we process it. And again, if you have any questions, let us know.
Absolutely. Thanks for joining, everybody.
Have a good night.